We've got one more session to go, and in some ways we've saved the very best for last. It's a fireside chat. It's about copay cards, the many shades of pay. By way of explanation, when a district court struck down a 2021 federal rule that barred copay discounts from counting toward patient out-of-pocket costs, the decision effectively barred insurers from applying copay accumulators for newer drug brands. Patient groups even fought off the government's surprising appeal. But the industry can't rest on its laurels. While accumulators may be dead copay maximizers and alternative funding programs aren't affected by the decision, this panel, it's not really a panel, it's a fireside chat, will put the accumulator case in the perspective of the larger cat and mouse game being waged between patient advocates and insurers. For this chat, please welcome to the stage Alisa Casavant, the Policy Director at the Arthritis Foundation, and our moderator, Lecia Bushak, my colleague and the Senior Reporter at MM+M.
Thank you to everyone for sticking around for our final fireside chat with Alisa. I really appreciate it. I'm excited to switch gears a little bit and talk about drug pricing. And an aspect of drug pricing that maybe is sometimes a little more overlooked than some of the other big conversations that the nation has been having in recent years, such as Inflation Reduction Act and Medicare negotiation, and the impact on the industry with those. And we're going to be talking about accumulator and maximizer programs, how those affect patients, and really where we stand with them today. And this is actually a pretty relevant topic because just today, actually just yesterday, the Centers for Medicare and Medicaid Services released the new Notice of Benefit and Payment Parameter Rule for 2025. And this is really relevant because essentially the takeaway is that the federal government is not going to be enforcing the district court decision that sought to strike down the use of accumulators. So Alisa, this seems like a pretty big setback for some of the advocacy groups that had been pushing for this. So before we delve into the details and the timeline of how we got here, what do you make of this news?
It's really amazing timing for this conversation, actually. So every year there is a new Notice of Benefit and Payment Parameters rule that comes out. This just came out yesterday. So most of us are still looking at it and seeing what's in it. But as you noted, the federal government is blatantly saying that they are not going to be enforcing the district ruling. That was a huge win for patients. We're honestly, collectively very disappointed. There's a huge letter with over 90 patient provider organizations, advocacy groups that have signed on to urge the federal government to enforce the actual court ruling. The disappointing thing is that every time that we are delaying care for patients, that means they are paying a lot more money out of pocket. It means they are not adhering to their medication. It means they are facing disease-worsening outcomes. And I think we have to bring it back to, why do we have patient copay assistance in the first place? It should be centered on the patient, not focused on profits. So this court ruling, really, we saw it as a huge opportunity for, hey, federal government, we're paying attention. We know that patients deserve the opportunity to afford their meds. And I don't think anybody is debating that cost of prescription drugs is expensive. We all are aware that patients are having a difficult time affording their meds. And I think it's important to remember that they're not just paying for medications. They're paying for their entire healthcare plan. So that MRI that they're getting, all of their tests for lab treatments and blood tests that they're having to go through, every time they see a specialist that costs $50 out of pocket, this opportunity means that they're not able to meet their deductible in time. It means they are paying a lot of money out of pocket. And most people just have, $600 to $1,200 in their bank account. So I always try to bring it back to, this is a terrible loss for patients at the moment for the government just to say, we're not going to enforce this right now. What they have told us in this ruling yesterday, or in the NBPP, is that they do plan to release a new rule on copay assistance at some point undetermined. But we all know how quickly the federal government moves right now, right? I'm sure you've all seen on the news. Very swift, very swift. So that's a delay. That's a delay in care. It's a delay in an opportunity for patients to get access to their meds. And it means that we're going to have to keep paying attention. It means we're going to have to reinvest our our own resources to track what they're doing to make sure that they know that we're paying attention and that we expect them to enforce the ruling.
So I want to come back to this, but first I wanted to backtrack a little bit and just talk about how we got here, and for you to give just a little bit of a primer on some of these definitions, like maximizers and accumulators, for some audience members who may not be too familiar with the terms. What exactly is an accumulator? Why do they matter to patients? And can you talk about also how they have historically been used by health insurers, and talk a little bit about that?
Sure. So there are these really fun terms that we like to throw out to confuse people. Around 2017, we started seeing accumulators enter into plan benefit design packages. What an accumulator is very confusing to patients and experts alike, but essentially it is a plan scheme that prohibits copay assistance from any third party, including manufacturer copay assistance, from counting toward the patient's cost sharing. So their deductible, their out-of-pocket maximum. So most of us we historically called them copay coupon cards. We call them copay assistance just to keep it a little more patient-centered. Say your medication costs $50 out of pocket. You're going to go to the pharmacy, you're going to pick up your med, you think, great, I've got this copay assistance for $40. I'm only going to have to pay $10 out of pocket. The issue is that $40 from the manufacturer copay assistance is not counting toward your deductible or your out-of-pocket costs. So it is delaying the patient's ability to have their plan kick in for the benefit from their insurer to help them. The maximizer is kind of similar. Plans are finding new ways to evolve. And a maximizer is when they take the maximum from the manufacturer copay assistance and they divide it evenly over the months. So kind of like a smoothing mechanism we see in the IRA, a little bit different though. So say the manufacturer is willing to give $12,000 for a specialty drug. They'll divide it by 12 months, so $1,000 per month. That's what they're saying, the plan or the PBM is saying. The patients should pay a maximum of $1,000 per month. But if the patient's maximum out-of-pocket cost is $9,000, they're way overblowing by thousands of dollars how much the patient is actually going to have to spend. And once again, not able to hit their deductible early. A lot of patients with chronic illness, arthritis is a huge one. There's over 100 different forms of arthritis, cardiovascular disease, cancer, diabetes. There's a lot of health conditions where patients are meeting that maximum out-of-pocket cost in March or in January. I see hand raised, myself included. So when you're trying to budget, we all are anticipating and are aware, I have my premium I've got to pay my deductible, I'm aware of my copay costs. I'm willing to do that budgeting, but how do I do it if I can't predict how much I owe? The other issue that we find is that now that maximizers are on the market, plans are continuing to evolve, and now we see the emergence of alternative funding programs, or AFPs. This takes it completely out of the plan altogether and puts it into a third party to manage the financial impact of that drug. So it's confusing. Patients don't know what in the world this is. It gets them out of their ACA-protected health insurance altogether, and it is just not transparent. People generally just don't even know what the difference is. These terms are confusing. Who in the world knows what a maximizer or accumulator? I mean, are we talking snow accumulation? Like, what is this? And so it's really complicated to try to explain to patients what to look for in your plan benefit design. Raise a hand, who actually reads the 100 pages in your health insurance packet besides me? Because yes, I figured we might, the nerds of us, we are the only ones, but most patients are not reading the fine print of their plan, let alone the plan summary. It just doesn't exist. And when you're looking, plans will often use a variety of different terms. They're not just using the term accumulator or maximizer. There are a whole host of other synonyms that they might be generous and call them copay assistance, but generally it's really hard to figure out what to look for to know that you should look in the first place and then what to do about it.
And, to add to this confusion for patients, there's been sort of this long saga between patient advocacy groups, the federal government putting certain rules in place, health insurers interpreting those rules and doing different things with those rules, different states kind of interpreting those rules in their own ways as well, kind of adding to that confusion. And there was a 2021 federal rule that was put in place that allowed insurers to not count prescription drug copay assistance toward a beneficiary's out-of-pocket costs for branded drugs that do not have a generic equivalent. And can you talk a little bit about why the federal government put that rule in place and ultimately why patient advocacy groups decided to sue the government over it?
Really good question. I would love to know what the government is thinking sometimes. CMS makes interesting decisions, and they allow for public comment to ask, hey, what do y'all think about this? What should we be aware of? There's a proposed rule and then a final rule. So we did have a large group of patient advocacy groups and provider groups that submitted comments. The court ruling in September 2023 was to strike down that 2021 rule. It took it back. It essentially reinstated the 2020 rule, which had stricter limits on accumulators. The problem is that accumulators are still allowed, so are maximizers and so are AFPs, and it reduces that impact on patients who rely on their meds without the generic options. There are a lot of specialty drugs that don't have a generic alternative, so patients don't have another choice. And I think it's also important when we're thinking about this, like patients have already stepped through other products to get to the drug that their provider is prescribing. They're generally not looking for, the first generic $7 drug. They would love to take that. But we're talking about infusions or, drugs that cost $250 a month or maybe $1,200 a month. And so the court ruling in 2020 really was a big opportunity. We're disappointed to see the government choosing not to comply with the court ruling, but it did strike that down. I'm not sure what they're thinking exactly, but I would really love to pick their brains more. And I think the important thing here is that there are rules every year, so they can always be updating, they can always be changing them annually. The NBPP is how the federal government operates federally regulated plans, so marketplace plans, ERISA plans, et cetera. So, yeah.
Yeah, and after that the district court decision in 2023, the Biden administration sought to appeal it, and this was one question that I was thinking about and actually talking about with Mark earlier was, the Biden administration has sort of been very vocal about its efforts to lower drug costs for Americans. Biden has touted the IRA and the Medicare negotiation as being, one of the major achievements of his administration, and he's planning on, touting that during the campaign later this fall. So it's interesting that the Biden administration actually was appealing the 2023 court decision. Yeah. Obviously, you may not be able to speak to the motives of that, but sort of where does that fall into place in this kind of larger claim to seek to lower drug costs for Americans?
Yeah, I think that's a really good question. From our perspective, any opportunity to get the conversation about effects for patients at the center of their healthcare is important. But how we take action in doing so is the question. I think there are good intentions. I have had many conversations with folks at CMS. I think that they believe that they're doing the right thing most of the time. I don't think that they are intentionally saying, hey, patients, forget you, we're going to side with the payers. I just don't think that that is the trend of the Biden administration. They have been very open to listening. They are open to feedback. They have been receptive. They're trying to figure out, listening to 500 different stakeholders or maybe thousands of comments that are being submitted, what is the right avenue as we're looking at increased patient expectations, increased patient demands, increased number of complex cases. Folks don't just have one condition. They have 4, they have 5. Most of us that are young and healthy, we have a hard time thinking about that, but if you are living with a chronic condition, the odds are you have other comorbid conditions. So looking at the opportunities for reducing costs across the board, we're all aware is part of the game, if you will. It's an opportunity to try to manage expectations, reduce costs to the whole healthcare system, understand that you might not be able to get that amazing blockbuster drug right away. You might have to step through a couple products that are less expensive to get to it. But we would always advocate as a patient organization that the importance of that decision-making should rest between the patient and their care provider. And any opportunity to get them the first med that their provider prescribes is what we should be doing. And so we have many organizations and coalitions that are working together to try to, converse with the White House, converse with agencies, and especially with Congress to take actions in a myriad of ways. So it's not just this rule that we're focused on. We're also working on a bill in Congress called the Help Copays Act that is moving. It's gotten a lot of bipartisan support and feedback. We have over 100 co-sponsors right now in the House. The Senate is really championing it as well. And that will be a way to codify what the court ruling is saying. So if there is a new NBPP, there's a new rule, perhaps we have a new administration at some point. It's important to codify this and make permanent these protections for patients. Lots of P's. The other thing that we're doing is working in all of the states. There have been several, I think 20 states plus Puerto Rico and DC now have passed state level accumulator bans or some variation thereof. This is important because not everybody has a health insurance plan that's regulated by the federal government alone. A lot of folks are also under state regulated plans, but we know about 60% of people have federally regulated plans. Most of us get our health insurance through our employer, which means they are ERISA plans. But we're leaving folks out. So we have to take this kind of trifecta approach of, hey, states, let's move here. Let's use you as the labs. Let's pass the state level. Let's also get it codified in Congress. And luckily, Medicaid and Medicare don't have to worry about this because they prohibit copay assistance altogether. So that this wouldn't apply for those folks.
So where we are now is sort of this gray zone. And can you talk a little bit about, for the average patient now, given the rule yesterday that just was released and the fact that the government will not be enforcing the court decision, what can the average patient sort of expect if they have an accumulator or a maximizer or one of these programs that is basically not allowing them to have their copay assistance be put towards their deductible? What would you tell patients to sort of how to educate themselves about these things? What can they sort of expect to see in the absence of policy, in the absence of this decision being enforced?
Yeah, so unfortunately, this really puts the impetus on the patient to do the heavy work. The heavy lifting falls to us as patient advocacy and hopefully some of our partners in the room to also get the word out. So we are part of a coalition called the All Copays Count Coalition that's really been spearheading this opportunity. We have created a toolkit for employers to know what to look for, to know how to communicate with your insurance broker when you're negotiating the next year's plan benefits for your employees. We've also created some toolkits for patients. So it really step-by-step walks through, like step 1, how do I pull up your plan benefits? Where do I go for that? Step 2, these are terms that are commonly used. How should I look through them? And then what do I do? If I do see this word, how to talk to my HR representative at my work, and then to provide some template language for folks so they don't feel overwhelmed by, I'm not the policy expert, but I see this word in my plan, now what do I do? So we're really trying to find ways of drafting letters, of giving them stepwise processes to look through their own plans, to get the word out. And then, for example, if employers do find such an issue in their plan, and they have already communicated with their broker or with their provider that they are not willing to remove the accumulator, which is now banned, so everybody should be protected. But if they are refusing to enforce the ruling, we can't add teeth to the game to make them comply. So opportunities to file a complaint, opportunities to contact HHS, to talk to your state insurance commissioner, and what would that look like? So giving template language is really, really important for us. But again, I don't know how many of us love calling our HR to say, hi, let me share my really sensitive personal health information, and I see this as part of the health plan. What are you going to do about it? So we've got to find a way to make it more easily accessible for people all over the board. All stakeholders have a share in this game. It's not just patients and it's not just employers. It's marketing, it's communications, it's figuring out with our pharma partners and other folks. How do we share the news that we are trying to apply pressure to make the core ruling exist?
And I wanted to sort of touch on the marketing and communication aspect of that. I believe, one of the statistics or something that you brought up in our previous conversation is that when patients face high out-of-pocket costs, they are less likely to adhere to their medication. They're less likely to, have positive health outcomes. And like medication adherence is, one of the goals of a marketer, and trying to make sure that patients are staying on drugs and they're able to afford the drugs. So what can marketers and healthcare communicators do to help sort of bridge this gap in knowledge? Because it seems like a lot of patients aren't even aware of some of these terms, as we've been discussing. Yeah. So what can they do to really help patients become more educated about it and sort of empower patients to learn more about, how they can afford these drugs?
Yeah, I mean, any opportunity to raise awareness is number one. Anytime that you can subtly insert it into a casual happy hour conversation this afternoon would be wonderful. We're really looking for new ways of explaining what the issue is, why it's a problem, and why it should be patient-centered. So any opportunity with all of our partners is really critical to getting the word out. I think we had also talked about, how do we get the word out? Not just what are the words, but a lot of patient advocacy groups or nonprofit groups, we rely on email a lot of times, social media, but we don't necessarily have the expertise of how to market. What does the language look like? We might have a marketing person, or maybe two, if we're really lucky. But often it's, me, the policy nerd, making a Canva Instagram post to try to figure out what in the world I'm going to say and who is my market. How do we get that word out further? That's where you all can come in to really be helpful and creating a larger audience, looking at different angles of how we might tell the story of patient copay assistance and why it's necessary. Because a lot of folks with accumulators in their plans are in high deductible health plans. That means that they're not necessarily able to afford, like we were saying before, they can't necessarily afford the $1,500. It's going to be a big shock when they go to a pharmacy, which also means maybe they're working 2 or 3 jobs. Maybe they don't have time to be scouring Instagram looking for this random patient advocacy group. So we got to find different channels to get the word out to. It can't just be one organization or one press release assuming that someone's going to read that publication. We need a plethora of different channels and opportunities to communicate to patients in a way that is understandable to them, which is not academic, which is more of a 6th to 8th grade reading level, which uses terms that are really friendly to them and really clearly states what they can do about it. So I welcome all of your support and help in this quest. We definitely need it, and we are working with some wonderful partners right now to figure out how to make additional FAQs or toolkits or what else might be helpful in the year to come.
And, where do patient groups like yours look to go from here? Because obviously, things are sort of left up in the air. We don't know when the government will be enforcing some of these decisions, if at all, in the future. There's kind of a bit of a gray zone for patients moving forward. So what do groups like yours hope to achieve moving forward? What do you hope to see in the future?
Well, for starters, we are doing a call to action campaign with advocates right now and just generally getting the word out to people to contact their Congress member as the most direct person that can apply influence to HHS in order to force them to get a little more pressure. Let's up the ante and make them realize, hey, we know that you're not doing this, please do it. So we are trying to apply more of a pressure campaign right now to let them know that we are engaged and we're paying attention. That's kind of an immediate term issue right now. Longer term, we certainly will be continuing to do comments. I think that some organizations may look to, are we going to need are we going to have to sue again to make the government do something? I think that's something that we're all kind of considering now that we've seen the most recent NBPP. Like, what are those next steps? And of course, it came out yesterday, so we haven't had time to regroup, but I anticipate there will be further opportunity for comments, public comments. There will be further opportunity for, these coalition meetings to figure out a strategy for longer term engagement. But I think really pushing on the Help Copays Act is one major step that we're taking on Congress, because we need to codify it, especially given an election year. Who knows what could happen with a new administration or a current administration continuing. Anything could be fair game for what we might see in a rule next year. So.
Great. Well, thank you, Alisa, so much for offering your expertise and for joining us on this panel. We all really appreciate your insight.
Thank you.
Thank you all.
Thanks all.